for a long time we've known that despite the fact that older adults make up the majority of our patients in clinic, they continue to make up a small percentage of patients that are actually put on randomized clinical trials that help define standard of care for these patients in clinic. And so one of the areas that we're trying to work on is trying to identify why is it that older adults are not put on these trials. And so some work that we've done through one of the cooperative groups in the US called the Alliance for Clinical Trials in Oncology is to try to identify if there are certain trial level variables that can predict for putting fewer older adults onto clinical trials. So a study that we worked on through the cooperative group was to look at the percentage of older adults on these trials compared to the percentage of older adults with that type of cancer during that time in the SEER database, which is a US-based cancer registry, and see if there was a difference, a disparity between the two, and try to identify which variables predict for that or are associated with that difference. And one of the more interesting findings that we found is that if the trials tended to have more modalities in them, meaning if it was a chemoradiation trial or if it was a chemoradiation and surgery trial, that those tended to have more difficulty accruing older adults compared to if it was just one modality, such as radiotherapy alone or endocrine therapy trial, which is not surprising. In addition, there are certain types of diseases that do a lot better at accruing older adults. So for example, GU, probably because of prostate cancer, did very well in accruing older adults into those trials, but GI cancers, CNS cancers, even breast cancer had a much more difficult time accruing older adults. And so one of the things that the Alliance is doing now is trying to improve on that by having a committee involved in almost the design of every single study. And in the Alliance, but I think it will be also very good to know, okay, well, these are the disease types that have difficulty, and we can kind of target those and say, okay, maybe they need age-specific trials in order to help better accrue older patients, which again is very important clinically, because if we're not studying those patients, we don't really know whether that standard that was set by that trial applies to the patients that we're seeing in clinic. Yeah, so it's hard to know based on the data that we have, because in order to really understand why older adults are not being put on trial, you need to kind of get down into the clinic itself to see, are the physicians not asking the older patients? Are the patients just not eligible because of strict eligibility criteria, like creatinine clearance or things like that? Or is the design of the study specifically done in a way to avoid putting older patients on? Meaning, are there age restrictions? Are there comorbidity restrictions? Are there having history of previous cancer restrictions can put older adults at increased risk, essentially, of becoming not eligible for the trials that we really need to put them on. And so, unfortunately, in our data, we don't have that level of detailed data, because this is all just trial level data, not specific patient level data. But we know from other studies that have been done that when older adults are eligible to go on trial and when they are asked to go on trial, they agree as often as younger adults do. So essentially, we need to do a better job of making sure that the trials that we are designing are easy to put older patients on. Well, I would just like to point out that there are lots of very good researchers that are working very strongly on this, including somebody named Rachel Friedman, who I don't know if she's at this meeting or not, but has been kind of leading the way in the Alliance for Clinical Trials cooperative group in order to help the entire cooperative group do a better job of accruing older adults. So I'd just like to kind of highlight her work as well.